Let's shift gears and let's start looking at why we use these modalities together, vacuum-assisted closure therapy and hyperbaric oxygen therapy. I think it's important to look at mechanisms to explain this. As we talked earlier, VAC has a number of mechanisms, vascular enhancement, bacterial control, as well as some stimulation of cellular proliferation. And interestingly, hyperbaric has many of the same mechanisms, stimulation of angiogenesis, antimicrobial effect, as well as stimulation of cellular factors. So it just made sense. By putting these two modalities together, we're going to get some synergy, and we're going to share our data with you. We looked at a group of patients, case-matched patients, and we found that when we treated these patients with either VAC alone or hyperbaric alone, that we used VAC for an average of 58 days to get to our endpoint of VAC use, and we used hyperbaric for an average of 18 treatments, again, before we got to the endpoint for treatment use. But very interesting, we looked at a group of patients where we used VAC and hyperbaric together, and what we found is, based on the synergism, realized we were able to decrease our average VAC use to 28 days and decrease our average hyperbaric treatments to 13. So I think this speaks very well to the synergies that can be achieved with using these modalities together. I wanted to talk about one paper that's in the literature that is often quoted as a negative paper using hyperbaric oxygen therapy. This is in a ischemic full-thickness wound model in rabbits. And Fabian designed the study in this fashion. He created hypoxic full-thickness wounds in a rabbit ear by ligating 2 of the 3 vessels that supply that ear, then performed 8mm punch biopsies, full-thickness wounds on 4 sites of the ear. He then randomized each ear to different treatment modalities, either with VAC alone, this is applying the sponge with no suction, VAC with negative pressure therapy, that would be putting the sponge down and hooking up to the pressure pump, VAC dressing alone, again, dry sponge and hyperbaric, or true VAC therapy, the sponge, pressure, and hyperbaric, and then treated these animals at 2.0 atmospheres for 90 minutes once a day for 10 days. Here's a little cartoon to show the ligation of the central artery as well as the rostral artery, leaving the caudal artery intact, and the sites of the biopsies. Here's a photograph of one of the rabbit's ears. This is how they performed the VAC dressing. This is an example of some of the tissue that was sent for histopathology, and measurements were then based on this wound. They looked at a number of parameters. They looked at the actual width of the wound and granulation formation based on changes in width, as well as changes in depth. You see different parameters, A, B, and C. And here's some of the data. This is looking at the depth of the wound. You notice that the hyperbaric, the group on the right, treated with VAC, whether it was with hyperbaric or without, there was no statistical difference between these groups. Although you do see that the hyperbaric group did have an increase in granulation over the control, or over the VAC treated without hyperbaric, but it was not statistically different. Here's looking at the width parameters, B and C, and again you'll notice that although there's an increase in granulation tissue when VAC is used versus the control, these numbers were not statistically different, and this is therefore reported as a negative study. Well, I think there's some problems with the study, and I'd like to address those. If you think back to the paper that I talked about a little earlier, where we looked at decrease in edema formation in our patients with a suction blister model, on day 2 we had a marked decrease in edema, and I think that plays a role here in this rabbit model. Look at that punch biopsy, a couple questions come to mind. Where do we measure the base of the wound? You can see it's very irregular. I've traced it in red, and are we measuring here? Are we measuring here? Or here? You can see there's 3 different parameters. And I can tell you with the difference in the measurements that I showed you in those graphs, this can be very, very different depending on where you measure. You know, is this true granulation tissue or is this debris? Now, if we decrease tissue edema, that wound is going to enlarge. So we're going to expect enlargement both laterally as well as towards the baseline. By decreasing tissue edema, you're going to flatten those measurement points out. And therefore, your wound is going to measure larger, or i.e. less presented as less granulation tissue. So you look back to those graphs, if we take into consideration that there was edema formation being reduced, these parameters are going to be very, very displayed erroneously, I think. So my observations on this study and the weaknesses on the study is that certainly there's several things that can be noted. Dry dressings clearly violates the current standard of care and violates the moist wound healing protocols. Dr. Fabian used hyperbaric for only 10 days, and clearly we only start to see the effects of hyperbaric right about this point. I don't think he did the study long enough. Also, as I suggested earlier, I think the measurements are significantly influenced by decreased tissue edema, and that would be noted in a hyperbaric treated group. And I think that based on this study, if you consider the edema reduction as part of the measurements, that we'd probably actually call this a positive study, because his data did show an increase in granulation of V.A.C versus V.A.C with hyperbaric versus non-hyperbaric group, although this wasn't statistically significant. So continuing V.A.C in the chamber, can you really do that? Well, we certainly do it every day, and we do that for a number of reasons. Some of the rationale is that we have enhanced clinical outcomes by having angiogenesis stimulated by V.A.C therapy and hyperbarically oxygenating and hyperoxygenating that tissue. I think there's certainly a synergy. And then Jack, can you speak about uninterrupted V.A.C therapy?
Well, sure. That, from a practical standpoint, that's a huge consideration. Some of these patients, especially with the larger wounds, we don't want to have to take the V.A.C dressing off to do an hour and a half or 2 hour hyperbaric treatment. So it's a great benefit to be able to just continue the hyperbaric treatment while they're in the chamber.
Absolutely. I'd like to introduce Greg Raleigh, our lead certified hyperbaric technician, who's going to take you through the technical components of how we actually do this on a day-to-day basis.